PhD in psychiatry from the University of London. In fact, he studied under my supervision some years ago. He also has an MSc in Affective Neuroscience in Maastricht in the Netherlands, and he is now has a position as Professor Doctor at the University of Sao Paulo, where he is head of the Stress and Affective Disorders program. Mary, I'll leave you to introduce the topic of your talk, and we're very interested to hear what you've got to say.
Thank you, Tony. Our talk will be about early life stress and affective disorders. We try to underline the Hpa axis and receptor function. Some of the previous speakers already talk a little bit about the Hpa axis, how stress could impact on hypothalamus, pituitary, and adrenal gland, and how these circulating cortisol can bind in these important structures of the brain system, mainly in these receptors, glucocorticoid receptors, and at the hippocampus at mineralocorticoid receptor as well. We already mentioned something about hypocortisolism in PTSD or even in chronic fatigue syndrome, like Tony just mentioned. But you have some evidence that some kinds of or some subtypes of depression, like melancholic depression, you can have higher cortisol activity and higher Hpa axis function. But when you talk about another type of depression, I'm not sure that you are all familiar with a typical depression that is the opposite of melancholic in the vegetative symptoms, mainly closer to chronic fatigue syndrome with higher levels of hypersomnia and sleep pattern, but you have lower levels of cortisol across the day. And so this is show different neurobiology of these two kind of depressions. And you review this in the is it in press, probably it's already Lancet. When you see the Hpa axis regarding stress in normal person, it's quite different from people with melancholic depression. You have hyperfunction here, and you have higher levels of cortisol that will not be really perceived by hypothalamus and pituitary in the receptors of this area. And you can include it here, chronic fatigue syndrome, but PTSD, atypical depression, and even bipolar patients, you have the opposite of melancholic. You have lower levels of CRH and ACTH, and you have lower levels of cortisol, but this is quite magnificent in the receptors at the Hpa axis and hippocampus. When you talk about trauma, I think most of the speakers talk about this important situation that is early life stress. And if you try to understand better what happens in different adult psychiatry disorders, even from schizophrenia, like Professor Potka talk, and about other kinds of situations in childhood trauma, you have different impacts in these disorders. But we published with Tony last year, actually was published this year, the childhood adversity on suicidality in clinical course in treatment-resistant depression. So you can see that even very diverse effects of suicide we can see in these situations. And you see that almost 3/3 of the childhood adversity express this poor clinical outcome. And this is really related with lifetime suicide attempts, or even predict lifetime psychosis when this child got physical abuse. The group of Columbia University from Jonathan Stewart just published last year that this subtype of atypical depression is associated with trauma. They saw that the history of trauma in this kind of patients with atypical depression can predict this kind of depression. As you can see here, almost 50%, more than 50% of these patients with atypical depression got lifetime trauma, and when you see the no atypical depression, this is lower than the patients with atypical depression. I work a little bit with Professor Ron de Cloé at the Netherlands, and I think he's a quite important reference for all the people that are studying this area. And I like this statement: if cortisol receptors are imbalanced and impaired, the individual lose the ability to stress adaptations. And so that's the reason that you are trying to understand better how cortisol can bind to these receptors. And even from the group from Mary Yogos, she tried to show the link, like Linda showed us before, how serotonin is quite linked to this system. And so if you got 100% of function in the serotonin system, if any of us got an acute stress, you can see that MR and GR start to work to recover this acute stress. But when we as clinicians, I am a clinical psychiatrist, try to help patients with several relapses and several recovers from depression or chronic fatigue syndrome or even other stressful situation, we start to help them with less than 20 or 50 or 30% of serotonin function. And this is even with the best antidepressant drugs that you have, or even with the best psychotherapists, probably you could not go further than 50% in these serotonin functions. And so if you try to understand the system, you can have some similar wellness with very different neurobiology patterns. And that's probably one of the reasons that you don't have at the moment specific agents that are working in these areas. The hyperactivity of the Hpa Axis, you can find atypical depression, for example, bipolar, PTSD, chronic fatigue syndrome, as Tony just mentioned. On the other hand, we can see hyperactivity of the system with melancholic depression, diabetes, and other chronic illness like diabetes. And so probably these two receptors are not in the optimal levels, and this is the proposal of Ron de Cloé group, that you should have the balance between the two receptors to try to make the glucocorticoid concentrations in the good levels to avoid this kind of illness. Regarding bipolar, you can see that in these studies with Rodrigo Machado Vieira, that works at NIMH nowadays, and Professor Wagner Gattaz, we found that manic patients in first episode were drug-naive patients in this manic episode, so lower levels of cortisol. Tony mentioned and published with Calypso, a colleague from the Institute, a very interesting data comparing these bipolar patients with unipolar. You can see they found as well lower levels of cortisol comparing to normal controls or even to resistant unipolar depression. In this paper that we published with Rodrigo Machado Vieira, we found a nice data, because you can link this with the understanding of atypical depression and melancholic depression. If you can see the cortisol levels using the Young Mania scale, when you got higher scores in the Young Mania scale, like elevated mood, you can see that you have the lower levels of cortisol. The opposite results you found when you analyze the irritability scores correlating with cortisol levels. You can see the higher scores of the irritability correspond to higher scores, higher levels of cortisol. And so you have a negative correlation between these 2 points, quite important points of bipolar diagnostic. And so when you try to understand this regarding the Hpa Axis and the receptors, you could not go further and think only about dexamethasone, that was the most studied synthetic glucocorticoid, because you can see it's a little bit different from cortisol. that is our endogenous glucocorticoid. It binds to GR and to MR, almost in the same pattern, but dexamethasone is a little bit different. Is much more a GR agonist than an MR agonist like cortisol. We developed, as Tony mentioned, the prednisolone suppression test that is not perfect, but is closer to cortisol and have almost the same selectivity. And now you are studying, you showed some data with the fludocortisone that is quite closer MR agonist. And so when we studied and developed these studies with prednisolone, we can see that the pharmacodynamic of prednisolone is closer to cortisol. The pharmacokinetic as well, the long life is almost the same, and it binds to CBG, a protein like cortisol does. And so this is interesting because you can assess the Hpa axis, as Tony said, in a more natural way. But that's the good news. The bad news is that when you publish this paper in the neuropsychopharmacology, using a very strong and potent antidepressant like clomipramine, you could not change the glucocorticoid receptor function in patients, just in healthy controls. As you can see here, use different corticosteroids, but the results are almost the same in patients. And so that's the reason that you don't have really potent antidepressants to treat these resistant depressive patients, at least nowadays. We just published last year this data regarding comparing the prednisolone suppression test, spironolactone and prednisolone, spironolactone, try to have in this combination a GR agonist without the MR agonist. And so this is the data of controls, and you can see that in controls it's work really well. But when you have the data of patients with treatment-resistant depression, it's associated with hypercortisolism. There are a MR malfunction in these, such as a downregulation. You could not see the difference between these in these kind of patients. Moving on to try to understand this resistance and try to see which one will be resistant or predict a response. Professor Hosbauer in the year 2001, more than 10 years ago, 13 years ago, showed this very interesting evolution of David Kupfer graphic when the progress of the disease goes to a symptomatic pattern, and then you could have two different activities of Hpa Axis, a low activity or a high activity. In the high activity, you can predict a relapse, and so you can say that these patients with melancholic depression could have a relapse at least 16 weeks later. And this is what happened when we did this study with the prednisolone suppression test. You can predict in the national inpatient unit at the Bafling, the patients that stay almost 4 or 5 months, which one will be the ones that will be responders in green or no responders. If you give a placebo tablet in the first day, you could not distinguish between no responders and responders. If you give in the first week 5 milligrams of prednisolone, you can say that, oh, these patients here with the same scores will be responders. And so this could be an interesting way to predict the role of the dysfunctional Hpa axis in treatment resistant. Moreover, you can see that these patients that supposed to be no responders or resistant, at the end, if they have the Hpa axis function, they will be responders, and almost the same pattern of control. And so you can distinguish really clear which one are the resistant patients to have more intensive treatment in these situations. And so I would like to show you some data of our unpublished paper that are at the moment in review in a high-impact journal. Mineralocorticoid receptor function as a predictor of treatment outcome in depression with and without early life stress. In another sample of 45 unipolar depressive patients, we found that more than 2/3, almost 70% of them, got early life stressful situation with abuse, physical abuse, sexual abuse, emotional abuse, neglect. We use CBT to assess them. And when you assess the depressant score, you can see that the outcome 60 days after inpatient treatment are really worse in patients without early life stress. Even with Montgomery-Asberg, you can see that. But more interesting, in my point of view, is that almost 93% of the patients with early life stress have suicide attempt. You see, it's quite different from the patients without a suicide attempt here, if they got in their history early life stressful situations. This is not happen with patients with this kind of depressive symptoms and without a history of early life stressful situations. And so you could say that these patients with high stress and depressed mood will probably have a risk to say goodbye, like this patient, to try suicide behavior. And so this is quite important for clinical practice, as you know. And you can see here, you use the Beck suicide inventory to assess the ideas of suicide in the admission of this unit. You got almost the same levels of suicide ideation, but after 60 days after, the patients with depression without early life stress almost got 0 ideas of suicide ideations, and the patients with early life stress got almost the same levels without a really improvement. More than that, when we split the sample in responders and no responders, you can say that according to Hamilton scores, you can say that almost 85% of them with early life stress will be no responders to guideline treatments. This is different in patients that are responders. And so the point is that you are working this area of the curve, and when you split them in the cognitive function and the cortisol levels, you can say that you are working patients with low ratio of MR and GR ratio. And so here are the typical depression, the PTSD, the chronic fatigue syndrome. You know, the opposite here are the melancholic depression. And to finish, I'd just like to show the paper that we published this year that is early life stress in depressive patients, Hpa Axis response to 2 different agonists, GR and MR agonists. You were looking for evaluate the changes of Hpa Axis and the function of GR in these patients with depression and early life stress. We really think that the persistent dysfunction, like Tony mentioned, that chronic fatigue syndrome, just after 6 months you got these situations, that we believe that the persistent dysfunction that will lead to another dysfunction that is maybe a keystone of this point, that is the MR dysfunction in adult depressive patients. And we assess them giving a MR agonist, fludrocortisone and dexamethasone the night before, and then you measure the cortisol levels, and then the CAR when they woke up 30 and 60 minutes after, and then you collected some other blood samples, and then you finish it, the 24 hours measured with saliva cortisol. Now you are starting a project with hair cortisol as well, and probably you can see other variables that could be assessed. Anyway, our results show for the first time that the MR in these patients are quite different. You know, MR agonist fludrocortisone were significantly lower in depressive patients than in controls. And we split the sample without early life stress. You can see that they don't have the difference between placebo and MR agonist. And with early life stress, probably both receptors are dysfunctioning because they are both different from placebo. When you try to correlate them, you can see that fludrocortisone, the MR agonists, are really correlated with placebo and GR as well. With placebo, but just in patients without early life stress. And you got the opposite. You got a negative correlations between the CTQ, the Childhood Trauma Questionnaire, and the MR agonist with both receptors, MR and GR, in patients without early life stress. When you assess the patients with early life stress, you just got a significant correlations between placebo and MR agonist, but not after GR agonist. And so here we control some variables like CTQ, the score and severity of depression, and the BMI in these patients. And so just to conclude, I would like to say that MR activity is impaired in these depressive patients when we compare them with healthy controls. When you assess the subtype of depression regarding the history of early life stressful situations, these patients are really sensitive to MR agonists. And in contrast with patients with depression without early life stress, they are sensitive to both MR and GR agonists. This data suggests that in these patients with early life stress, an imbalance exists between MR and GR, with probably MR dysfunction that you should see in further studies to assess these points. You know, Professor Alan Young from the Center of Affective Disorder published this very prophetic paper in the year 2000. Further therapeutic targets in mood disorders, the glucocorticoid receptor. I think you should add that not only GR but MR are really future targets for assessing these situations. And I just like to thank the group that helped me to develop these. Tony is here. It's a great pleasure to work with you in the last 10 years, 12 almost. Andrew Papadopoulos, a very good friend of us, Carmine Parianti, Lucia Poon, and the group that I'm working at University of São Paulo as well. And I'd like to thank here Pedro Lima, that he was my first mentor, and he is one of the mentors of the World Congress on Brain, Behavior, and Emotion. Thank you very much for your attention.
So I think we've got time for one or two questions for Mario, and then we'll have 10 minutes for a panel discussion. So any questions for Mario first? No? Okay, well, should we get the other two speakers and have a panel discussion for any questions anyone from the audience wants to raise? Do you want to come and join us?